I'm Leslie Lieberman. I'm the Director of Special Initiatives and Organizational Consulting for the Health Federation of Philadelphia. So I've been a social worker for almost 30 years, hard as that is for me to believe. And before that, I was raised as the daughter of an academic psychologist and a clinical social worker. So in some ways, I feel like I've always known about trauma and the impact that it has on individuals and communities. I've always known about human suffering and really from a very early age felt that I had both a personal and professional responsibility to do something about it. But I didn't really know about trauma, toxic stress, the adverse childhood experiences study and other research that supports what we now know about how adversity impacts children and individuals and families until I came to work for the Health Federation about 9 years ago when I was hired to direct a new initiative called Multiplying Connections. And ironically, I worked for Kaiser Permanente, which, as you know, is where the adverse childhood experiences study was done for almost a decade before that, and had never heard about the ACEs study. And interestingly, though, I knew about it anecdotally, and at the time I was at Kaiser, I directed a program, a perinatal substance abuse program, where we were integrating substance abuse identification and intervention into routine OB care. And as part of that, we began to recognize that many of the women who were struggling with addiction during pregnancy had experienced bad things as children, in particular child abuse and sexual abuse. And so we didn't have a name for it, but it was the ACEs study. So, for a lot of people, learning about the ACEs study and the other neuroscience is an aha moment. For me, I think of it more as an moment when many things that had been sort of disparate and not well connected for me kind of came together. The other thing is that as a young social worker, I was also fortunate enough to be exposed to a public health perspective. I worked for a county public health department as my second-year internship and then continued to work there for about 4 years in a very innovative program called the Prevention Program, where we really did a lot of work on the underlying causes, which we now call social determinants of health, but back then we called them the underlying causes. And so I learned early on that really every leading cause of morbidity and mortality has an underlying social, environmental, economic component to it. So as I said, learning about the ACEs study and then more broadly the ACEs framework was really an moment for me, validating sort of all these disparate pieces and making sense of them and having this science to underpin it and then make connections with others. So I was going to start with talking about sort of what did I do when I learned about this information about specifically the adverse childhood experiences study and then also the neuroscience that really helps us understand why ACEs have the impact that they do. So the first thing that I did after I learned about this when I came to Philadelphia was, as I said, I'm the daughter of an academic, get my hands on as much literature as I could to learn as much as I could about the ACE study, about the neuroscience. I looked at the work of people like Bruce Perry and Bessel van der Kolk, and I also searched out mentors in the Philadelphia area, one of whom was Sandy Bloom, and other pioneers in locally, Kalma Cartel White, who had been doing this work for years, and learned as much as I could from the literature, from the mentors, and then began to think about how can I apply this to the work that I have been charged with doing in the Multiplying Connections Initiative. And the Multiplying Connections Initiative, its initial mission was to build capacity in the public systems that serve young children for trauma-informed practice. So I began to apply all of this new knowledge to think about how do we make this information really accessible and meaningful to people who are doing the day-to-day work in the trenches of serving children and families who have either been impacted by trauma or are at risk for being affected by trauma. And that led us to develop a number of resources and tools, including a set of core competencies for trauma-informed and developmentally appropriate care, a foundational curriculum called Becoming Trauma-Informed, which really tries to lay the groundwork across systems for basic information, what everybody needs to know about trauma, very much informed by a lot of the work that Dr. Bloom pioneered. And actually, as we rolled that work out, it also led me to make connections with other related fields that in some ways I felt had needed to be brought into the framework of trauma-informed practice and ACE-informed practice. So one of those, for example, is reflective supervision. And reflective supervision or relationship-based supervision is a model which supports people who are doing work with people who've experienced trauma, and is one of the things that I learned about that is in the literature is not only do people who interface with our systems experience trauma, but people who provide those services to people who interface with services set up to serve vulnerable populations also can experience what's called secondary traumatic stress, which is their exposure to the trauma because of the people that they're serving. So reflective supervision really felt to me like a perfect model that needed to be integrated into what's expected of a system or an organization that's doing trauma-informed practice. So I've spent with colleagues a lot of time trying to promote the concept of reflective supervision and put into place structures to help professionals learn how to do reflective supervision and practice reflective supervision. So those are a few of the changes that I've helped to facilitate in Philadelphia. So the Philadelphia ACEs Task Force began in, I think, around 2012, and it was initially spearheaded by an organization called the Institute for Safe Families, which had been working for many years on how to prevent interpersonal violence and at multiple levels, and had really, similar to my experience, found the ACE framework to be an excellent way of kind of connecting the dots in the work that they were doing. And they had also had a lot of focus on working in pediatric settings to really try to promote screening for domestic and intimate partner violence in pediatric settings, and help, in particular, healthcare providers develop the skills and capacity to work with families who were experiencing interpersonal, intimate partner violence. So the Institute for Safe Families, or ISF, brought together a small group, maybe 25 people who, this was 2012, who'd already, kind of been working in this area of ACEs and trauma-informed practice and toxic stress together and had identified 3 physicians to co-chair the Philadelphia ACE Task Force: Dr. Sandra Bloom from Drexel, Dr. Joel Fine, who is an ER pediatrician at Children's Hospital of Philadelphia, and Dr. Lee Pachter, who's with our other children's hospital in Philadelphia, St. Chris. And first of all, that in and of itself was a kind of a reflection of the work we were trying to do as the Philadelphia ACE Task Force, which is bring together organizations that may not have always worked so well together, may have in fact at times been competitors, but recognizing that part of what we need to do to really move this work forward is break down the silos that sometimes separate our organizations and institutions. So, and the ACE Task Force came together really with the initial mission of how do we integrate the knowledge about ACEs, the science of ACEs, the science of the neuroscience behind ACEs, what we understand about toxic stress, into pediatric care. And that was really the initial focus for about the first 2 years of the task force. And then in 2014, the Institute for Safe Families closed its doors and transitioned their portfolio, the staffing of the ACE Task Force, to the Health Federation of Philadelphia. The 3 co-chairs remained in place and thankfully still are co-chairing the task force. And over that period of those 2 years, the task force membership really expanded. It started out as an invitation-only group, yet they had a policy that nobody was excluded. So people began to hear about it. There was a lot of buzz in Philadelphia, and people really wanted to be part of really what was a growing movement in Philadelphia to become a trauma-informed city and to apply an ACE framework to the work that we do. And over those 2 years, membership moved beyond just kind of the pediatric sphere. There were representatives from education, there were funders at the table, there were juvenile justice, much broader. And in 2014, we really recognized that, and I think the work in those first 2 years had really been around networking, around awareness building, around coming to some shared vision and understanding of what we wanted to do in Philadelphia. And a primary actually task that was accomplished in those initial 2 years was the Philadelphia ACE survey. So that gave us some real data and information about what do ACEs look like in Philadelphia. So as I mentioned, Philadelphia, part of the initial work of the ACE task force was to conduct our own Philadelphia ACE survey. And we recognized in Philadelphia that the original 10 ACE questions did not probably capture all the types of adversity that Philadelphians experience. And so to those what we now kind of consider the traditional or original ACE questions, we added a number of questions about whether or not people had ever experienced racism, bullying, community violence, feeling safe in their neighborhood, to really capture what we thought were types of adversity that we were likely to find in Philadelphia. And those questions were added on to a telephone survey that is done by an organization, I think, every other year in Philadelphia. And 1,700 adults were surveyed by telephone about a number of health questions like the original ACE study did, along with the Philadelphia ACE survey questions. And no surprise, I don't have the statistics at my fingertips, but we found that on the traditional ACEs, in almost every category, residents who lived in Philadelphia had higher ACEs than in the original study, and that the expanded ACEs really identified a number of types of adversity and were also correlated to mental health and health issues that would not have been identified had we only used the traditional original 10 ACE questions. I think that we have encountered resistance in some ways over the course of this work that I've been involved in for 9 years. And some of it is, I think that much of it is what I'm going to call well-intentioned resistance. It is not overt, but it is around priorities, I think, that systems and organizations are dealing with. And so some of our systems in Philadelphia have gone through tremendous change in the last 9 years, really overhauled the whole way that they deliver services with the intent and the goal to deliver services in a better way. But I think that sometimes inadvertently those changes make it more difficult for us to really move forward with an agenda to promote a trauma-informed approach to care. And so that's most of the resistance that I've experienced. And I think the other piece is that really a trauma-informed approach requires that we begin to really break down walls, silos, and there's still a long way to go on that. So those are that's the most types of resistance that I've encountered. The other piece, I think, that we have to keep in mind in terms of thinking about resistance, and is that it's a long-term journey, and we're not at the end point yet. I don't know when we'll get to the end point, and so we do have to keep in mind that we're all, those of us who are doing this work, need to be in it for the long haul, for our lifetimes and the lifetimes probably of the next generation of professionals. But it also, I think it's really important to keep in mind that for all of us, at some level, it's a very personal journey, and sometimes a very personally painful journey. I think this can also be a part of the resistance that is less tangible to capture, but I believe is there. So part of what I do through the Health Federation and Multiplying Connections is a lot of training on the ACEs and trauma. And we believe always that for the first time when people are hearing this information, if they really aren't familiar with it at all, if they're professionals, they're not hearing it with their professional hat on. They're responding to the information personally, and they're thinking about, wow, what does this mean for me? What does this mean for my family? What does this mean about my community? And people have to hear it multiple times over before they can engage in it at a different level than that very personal level, before they can apply it in their work, before they can get involved in the movement. So I think there's that kind of resistance, which really requires that, in spite of the fact that sometimes we feel so much urgency about this issue, we also have to have patience and compassion for how long it takes some people to get on the road. So thinking about what this journey has meant in Philadelphia and what it may mean for other cities, some of the advice I would give is that we do have to keep the long-term vision in mind. We have to be patient, and we have to also make sure that when we are communicating about ACEs and about toxic stress and about trauma, we're also communicating the messages about hope and resilience. I think that's another lesson that we have learned on this journey, that the messages need to be really intertwined, so that people don't fall out of this work because it is all just gloom and doom. And we need to be able to share some of those hopeful stories and those signs that things are moving forward. And so I think advice is to other cities is, have your ACEs data, because that gives you a picture of your community, but also it's got to be combined with storytelling, both stories of people's personal journeys, but stories of hope and resilience and recovery as well. I think that we need to continue to build awareness. That's a piece of it, but not feel but recognize that's a starting point, not an ending point. And one of the things that I have seen is, I think sometimes communities, including sometimes our own, get stuck at that awareness building place that we can do a lot to spread the information, communicate about it, but we really have to think about what the next step is. And that requires, again, that's part of the bringing together of people from all of the different sectors that trauma and ACEs intersect with, working to break down those silos between those sectors and identify shared common vision. And also, I think part of my advice is that those who are spearheading it need to be the dot connectors to help folks who are working on single issues like child abuse, like domestic violence, like human trafficking, like hunger and poverty, how all these dots connect and why it is important for us to all come together and how we can together do more than we can alone. In thinking about what the next public policy thing that we need to focus in on, in addition to what I've already said, I think we really need to use and capitalize on the ACEs science and the framework that ACEs provide around the social determinants of health to shift a public narrative around how do we create safe, secure, a safe, secure world for all of us. And I think we need to really to promote the message that ACEs is about all of us. I know I've had the conversation with Dr. Bloom a few times about what it would mean as a woman to feel safe on the streets at night. And so I believe that ACEs and trauma affect all of us, and until we have safety for everyone, we don't have safety for anyone. And I think that's the primary message that we need to promote and be aligned across our organizations, our systems, and in the policies that we make to make sure that we're working toward that. So thinking about what would it look like 10 years from now if Philadelphia were a trauma-informed city. I think that it would mean that no child born after, let's see, what year would it be, 2026, is that right, would ever have an ACE score above 2. And there are some places in the country now that are really looking at that as a marker. What an unbelievable place we would live in if no child had an ACE score above 2, and thinking about what that would mean for the generations that come after that. And in order to get there, we have a lot of work to do. That means we need to think about issues such as hunger, as poverty, as what kind of recreational spaces do we have for Philadelphia citizens? How trauma-informed are our systems and organizations and services? And even beyond sort of thinking about trauma-informed, how welcoming and responsive are they to people who have experienced trauma, and what are they doing to prevent trauma? We have a long way to go. I'm hopeful we will get there, and I continue to want to do the work with others that have been part of this series, and really believe that we can get there.